This paper presents a summary of the 2024 guidelines on the treatment of relapsing, metastatic, and castration-resistant prostate cancer. Post-radical prostatectomy, a rising PSA level above 0.4 is the most predictive threshold for future metastases. The Phoenix criteria define PSA failure after radiotherapy as a PSA increase greater than 2 above the nadir. However, there are no validated PSA endpoints post-HIFU or cryotherapy. Patients which develop BCR can be subdivided into low risk and high risk based on clinical characteristics. Regarding imaging in PSA-only recurrence, studies demonstrate that PSMA PET-CT can detect recurrences at PSA levels as low as 0.2, offering an acceptable sensitivity in this setting. This allows for early detection of distant metastases, which must be ruled out in patients with local recurrences who are fit for salvage therapies. On top of this, MRI is effective for detecting local recurrences after radiotherapy, and hence can guide biopsy and subsequent local salvage therapy. In the setting of PSA-only recurrences after radical prostatectomy, trials such as Radicals RT, RAVES, and GETUG AFU17 indicate that initiating SRT at PSA levels below 0.2 results in a 5-year biochemical progression-free survival rates of 87 to 90%. Moreover, other studies have shown that delaying SRT until PSA exceeds 0.25 is associated with a greater risk of all-cause mortality. And negative imaging findings should not delay SRT if it is otherwise indicated. Regarding adjuvant radiotherapy, this still has a role in highly selected patients with adverse features. And with regards to combination with ADT, the GETUG AFU16 trial showed that adding short-term ADT of 6 months to SRT improved overall survival by approximately 15% over SRT alone. And moreover, the NRG Oncology RTOG 0534 support demonstrated that the highest 5-year progression-free survival of 87% was obtained using prostatic bed radiotherapy, pelvic lymph node radiotherapy, and 6 months ADT. On the other hand, regarding PSA-only recurrences after radiotherapy, options include ADT, salvage local procedures, or, if a EAU low-risk BCR, a wait-and-see approach. To this end, a systematic review and meta-analysis compared the various salvage therapies and found that the 5-year recurrence-free survival rates ranged from 50% after cryotherapy to 60% after high-dose rate brachytherapy and stereotactic body radiotherapy. However, severe genitourinary toxicity was highest with HIFU and radical prostatectomy, exceeding 21%, compared to up to 8% for re-irradiation techniques like HDR brachytherapy. Regarding hormone therapy for relapse, ADT should not be offered to patients with MO disease and a PSA doubling time greater than 12 months. However, it is recommended to offer enzalutamide with or without ADT to patients with M0 disease who have a high-risk biochemical recurrence, as defined by the EMBARK trial. High-risk features include a PSA doubling time of less than 9 months and a PSA level of more than 2 nanograms per ml after radiotherapy, or more than 1 after radical prostatectomy, with or without postoperative radiotherapy. The EMBARK trial demonstrated that in such high-risk patients, enzalutamide, either in combination with ADT or as a monotherapy, significantly improved 5-year metastasis-free survival, with rates of 87% for enzalutamide plus ADT and 80% for enzalutamide monotherapy. Regarding first-line hormone therapy in metastatic prostate cancer, primary ADT has been the standard of care for over 50 years, with no significant evidence favoring one type over another for oncological outcomes. However, LHRH antagonists and orchiectomy lead to a faster testosterone reduction, making them preferred options for patients with impending complications like spinal cord compression. Additionally, LHRH antagonists may have fewer cardiovascular side effects compared to LHRH agonists, making them a better choice for patients with cardiovascular risk factors. Regarding combination therapies, and in particular chemotherapy, an individual patient data meta-analysis of 3 large randomized control trials show that adding docetaxel to ADT significantly improved overall survival in men with metastatic prostate cancer, with a hazard ratio of 0.77 and an absolute 4-year survival improvement of 9%. The greatest benefit was observed in patients with high volume and stage 4 disease, and based on these findings, upfront docetaxel combined with ADT is a standard treatment for metastatic prostate cancer, provided patients are fit enough to receive it. However, with recent evidence supporting the addition of androgen receptor pathway inhibitors to docetaxel and ADT, docetaxel alone should only be considered if RPs are unavailable or contraindicated. Indeed, adding RPs to ADT significantly improves outcomes in men with metastatic hormone-sensitive prostate cancer. The STAMPEDE and LATITUDE trials showed that adding abiraterone acetate plus prednisone to ADT reduced risk of mortality by approximately 38%. Other RPs such as enzalutamide and apalutamide were also evaluated in large trials. In the ARCHES trial, enzalutamide improved radiographic progression-free survival with an HR HR of 0.39, while Enzamet showed that a significant overall survival benefit with an HR of 0.67 was sustained over a long-term follow-up. Additionally, the Titan trial found that adding apalutamide to ADT improved both radiographic progression-free survival and overall survival. And finally, the CHART trial demonstrated that redvalutamide with ADT significantly improved radiographic progression-free survival and overall survival compared to bicalutamide in high-volume metastatic disease, with a hazard ratio of 0.44 and 0.58 respectively. Moreover, triplet therapy combining ADT, docetaxel, and ARPs like abiraterone or darolutamide have shown significant benefits in metastatic prostate cancer, as demonstrated by the PEACE-1 and ARASENS trial. With regards to treatment of the primary tumor in newly diagnosed metastatic disease, the STEMPEDE trial showed that prostate radiotherapy in men with low-volume metastatic disease, including M1A disease, showed significant benefit with an HR of 0.64 when assessing overall survival when added to systemic therapy. Similarly, regarding metastasis-directed therapy in men with oligorecurrent prostate cancer, combined data from the STOMP and ORIOL trials confirmed improved progression-free survival with MDT. That said, while biochemical response rates, which were defined as a PSA decline of more than 50%, were encouraging, with a 60% response and a 22% complete response rate in a related study, there is currently no hard evidence of improved overall survival, and MDT remains investigational pending results from ongoing trials. Next, patients with metastatic castration-resistant prostate cancer should undergo somatic and/or germline molecular testing, including screening for mismatch repair deficiencies or microsatellite instability. In Europe, there are numerous approved treatment options for metastatic castration-resistant prostate cancer. However, a word of caution when sequencing ARPs like abiraterone and enzalutamide, as this is generally not recommended, especially if there is a short response time to ADT or the first ARP and rapid progression is observed. Finally, before diagnosing CRPC, it is crucial to confirm that testosterone levels are indeed below 50 nanograms per deciliter, and importantly, treatment decisions for CRPC will also depend on the therapies to which the patient has already been exposed. Regarding first-line treatment, PARP inhibitors have an important role. Combination therapies of ARPs with PARP inhibitors in first-line metastatic castration-resistant prostate cancer have shown promising results, particularly in patients with BRCA mutations, but also come with significant side effects. The PROPEL trial demonstrated a significant radiographic progression-free survival benefit with abiraterone and olaparib, particularly in patients with BRCA mutations who saw a more substantial improvement with an HR of 0.24 and an overall survival benefit with an HR of 0.3. The most common side effects experienced was anemia, with 18% requiring blood transfusions. Based on these findings, the combinations of olaparib and abiraterone has been approved by the EMA for a broader mCRPC use and by the FDA specifically for BRCA-mutated patients. Similarly, the MAGNITUDE trial found that adding niraparib to abiraterone significantly improved radiographic progression-free survival, again demonstrating a greater benefit for BRCA-mutated patients. And thirdly, similar findings were also present in the TALAPRO-2 trial, assessing a combination of enzalutamide with talazoparib. However, while these combination therapies offer promising benefits, particularly in patients with BRCA-mutated subpopulations, no clear overall survival benefit has been consistently demonstrated across the trials. The potential benefits must be carefully weighed against the increased risks of side effects, particularly anemia, as seen across all studies. All patients who receive treatment for mCRPC will eventually experience disease progression. There is a high-level evidence for second-line treatments after first-line treatment for mCRPC with docetaxel or ARPs. However, limited data on sequencing treatments after pre-treatment with both is present. In this setting, cabazitaxel is a key option, especially for patients with rapid progression on AR-targeted therapy. In the TROPIC trial, cabazitaxel improved median overall survival to 15 months compared to 12.7 months with methoxantone. Cabazitaxel also showed superior radiographic progression-free survival and reduced mortality risk compared to another ARP in the CARD trial, making it crucial for patients progressing after docetaxel and an ARP. In this setting of second-line treatment, other treatment options include radium-223, lutetium PSMA-617, and the PARP inhibitor rucaparib. Finally, preventing skeletal-related events is important. Bisphosphonates such as zoledronic acid have been shown to reduce skeletal-related events in mCRPC, particularly by lowering the incidence of pathological fractures. In a trial involving approximately 650 patients with CRPC and bone metastasis, zoledronic acid reduced the rate of SREs from 44 to 33% at 15 months. However, no survival benefit was observed. Denosumab, which is a rank ligand inhibitor, also delayed SREs more effectively than zoledronic acid, but similarly did not improve overall survival. Both treatments carry risk of osteonecrosis of the jaw of up to 8% in mCRPC and hypocalcemia, which means that these patients necessitate careful monitoring and preventative measures, such as ensuring adequate calcium and vitamin D intake. Current recommendations prioritize these agents for managing bone health, however, emphasize their lack of survivable benefit and the need to mitigate side effects.